So first off, I just want to talk to you guys about Canvas. A lot of people just didn't take quiz number 2. If you didn't take it in time, you're not going to get to take it because it was available for like 5 days to take it. So if you didn't take it until the last second, then it's not really that sad that you missed it, you know? So I leave these open for so long so you can take them. Doesn't mean you need to take them all 5 minutes before, and then when it shuts you off, everyone emails me asking if they can take it again, and you can't. So you need to pay more attention to the due dates. So looking right here, you can see February. Obviously, if you click on it, you can see when it was due. So you need to keep a little bit better track on that sort of thing. So like we have a knee activity that's due March 3rd. This one is at 11:59. Okay. So now we're moving on to the hip and pelvic girdle, part 1. So for the hip and the pelvic girdle, the hip is going to be made up of the femur, which we already learned, the distal femur, and what's called the pelvic girdle. So the pelvic girdle is made up of a couple of bones, your innominate bones, your sacrum, and your coccyx. Now your innominate bones are going to be the like ear-shaped part. So right here you can see those innominate bones. The sacrum is this little butterfly piece that has all the holes in it. And then our coccyx is going to be our tailbone. So the femur plus your pelvic girdle, all of this, is what equals the hip. Now your pelvic girdle is going to be what attaches your legs onto the rest of your body as well. So, if we look at the bony landmarks, so now this is going to be our proximal femur bony landmarks. So we're going to start out with the head. So the head of the femur kind of looks like a human head. It's very round and circular. So the very top aspect is going to be the head. Is this public for you guys to view yet on Canvas? Do you want me to make it public really fast? Let me make it public. Okay, there we go. It's on there now. Okay, sorry about that. So the head is this top rounded aspect. And then just like in people, the head's going to lead to the neck. So then we are going to have our neck of our femur, which is the skinnier portion right underneath the head. So if we look at a model of it, it's pretty easy to see where the head is, that whole rounded aspect. And then you can see the neck is going to be pinched off right here. So you got kind of like this like skinnier aspect, and then it balloons up to the head. So the neck is where a lot of fractures happen because it's a lot skinnier. Okay. Then we're going to have our greater and lesser trochanter, which we kind of talked about last time for some of our muscle origins. So that greater trochanter will be this lateral bump coming off the side, versus our lesser trochanter is the smaller bump medially, because it's lesser in size. So we know if we're looking at the top of the femur and we can't see the bottom, We always know that the femoral head sticks medially, so we know this is going to be medial no matter what. So if we look here, we can also see, if we don't know just lateral and medial, the greater trochanter is obviously going to be a lot greater in size. So you can see from the back how much bigger the whole greater trochanter is versus this little part of the lesser trochanter. So greater is lateral, lesser is medial, and obviously in size. And you can see that from both anterior view, greater, lesser, and posterior view, greater, lesser. Okay, next is the linea aspera. So linea means line. So the linea aspera, it's a little bit harder to see. If we look on here, we can see we got a little bit of a crest forming in the back. And we can see up on here, we have like a crest. You can really see it better on this one. See how you got this line coming down the back? It's kind of a pulled up piece. That line going down the back of the shaft of the femur is the linea aspera. So going down right here, and we'll have a few muscles that will attach there. So next we have our intertrochanteric line. So the intertrochanteric line and the intertrochanteric crest are sort of interchangeable, honestly, and you seem to find it written different ways. So sometimes people say the intertrochanteric line is on the anterior view going this way, but sometimes people say the intertrochanteric line is going on the back. So really just think anytime we're having a line in between the two trochanters is going to be our intertrochanteric line. And because it's a divisive thing, I'm never going to ask for it on the test or anything. Any questions on femur? Okay. So with our pelvic girdle, we know the first portion is made up of the innominate bones. So our innominate bones are going to be these wing parts. So all of this and all the way down here is all the innominate bone. But your innominate bone is made up of 3 regions. So as you age, so when you were little, these are not attached in any way. So you would have like a small little circle bone up here, small little bone right here, small little bone right here, and they aren't connected. So that as you age and grow, you will grow your bone, grow together, and then this is where they would all fuse kind of at like a growth plate. So they originally are 3 separate bones, and then once you reach full grownness, it will become one of the innominate bone, or it's also called your os coxae, is a singular one, os coxae. But it is made up of your ilium, your ischium, and your pubis. So this is a lateral view, so we're looking at it directly from the side. So we're looking like this. The top upper portion is the ilium. So this top kind of winged out portion is going to be the ilium. The pubis is going to be anterior and lower. So the front aspect is going to be the pubis, because we know this is the pubic symphysis. And then lastly, we're going to have the ischium, which is the green part. It's going to be posterior and lower. So that will be the back of this. So if you remember, we had the ischial tuberosity, because it's on the ischium. So ilium, ischium, pubis. So all 3 make up the innominate bone or the os coxae. Any questions on that? Okay. So there's a lot of bony anatomy, bony landmarks for the pelvic girdle. So pelvic girdle continued. There's a lot of stuff to learn on this one. So starting out with the iliac crest. So the iliac crest is right here. It is the whole top of that ilium. So that would be, if you put your hands on your hips, that's your iliac crest. Everything you feel when you put your hands on your hips. So this whole region, this very top spot, is your iliac crest. Top of the ilium. Our acetabulum is next. Acetabulum is viewed laterally. So our acetabulum is this shallow kind of groove, this circular groove on the lateral side. Now this is where the head of the femur sits and inserts. So if we look on our skeleton, we can see that there's this circular groove that allows the head of the femur to sink in where it would attach, and then there'd be a labrum around it as well. So that is our acetabulum. So next is our anterior inferior iliac spine, which you already sort of know because we talked about it. So that is abbreviated AIIS. You can write it that way as long as you know what the rest of it means. So that way on tests you would be able to do it right. We also have our anterior superior iliac spine, ASIS. So if we look, the anterior superior iliac spine, ASIS, is going to be the most anterior region, the kind of end of the iliac crest. So if we follow that iliac crest all the way around, where it terminates anteriorly is going to be that ASIS. So if we look here, coming all the way around, once it reaches the tip, that is that ASIS. And we can view it laterally as well. So you can see top of the iliac crest, ending at the ASIS. So then our AIIS, which is anterior inferior, is obviously going to be inferior to the ASIS. So we can follow it down again, and we're going to have kind of a divot right here, and then it will pop out again, just kind of above the acetabulum. So then this bump will be the AIIS, and if we look laterally, there's the ASIS, scooping in, AIIS above the acetabulum. So we can see here, ASIS, scoop, AIIS. And we learned those yesterday because, or not yesterday, last class, because of the bony anatomy. So we're also going to have a posterior iliac spine. We have a posterior superior iliac spine and a posterior inferior iliac spine. So basically the same thing as anterior, but for posterior, I just want you to know posterior iliac spine. So that will be the opposite way. So if we follow that iliac crest posteriorly, where it terminates at the end is going to be the posterior iliac spine. So you can see that on this view where it goes all the way back, and then it ends right here, that kind of bump. Going to be that posterior iliac spine. We also are going to have our ischial tuberosity, which you already learned because that is where the hamstrings attach. So if we know this is our ilium, this is our pubis, this is our ischium. The ischial tuberosity is kind of at the very end of it, or the inferior aspect, and it is this hard bump right at the bottom. So ischial tuberosity. So if we look on here, right here is going to be our ischial tuberosity. We are then going to have our pubis and our ramus. So basically our pubis is what we're going to be referring to everything as. So our pubis, if we're looking at an anterior view, our pubis we know is this whole region But basically, when we talk about the pubis, we're going to be referring to very close to the pubic symphysis, so right in here. So this region right here will be our pubis. You can see on this picture as well, pubis. The ramus is just below it, but we're just going to say pubis. So all of right here is going to be our pubis. And last thing on here is your sacrum and your coccyx. So from this view, you can see our sacrum right here. So again, it's kind of that like butterfly, or like, I think it looks like a stingray personally. Like its little eyes and then little like nose things. So stingray shape with our little holes. So that is our sacrum. And then connected to our sacrum is going to be our coccyx, which is this very end little tip, bless you, which that is going to be our tailbone, so coccyx. So we've got sacrum, which we can see, and then the tip of it is going to be our coccyx. Any questions on pelvic girdle? Okay. So joints in the pelvic girdle specifically, we're going to have two joints. We're going to have our pubic symphysis and our sacroiliac joint, or our SI joint. So you've probably heard of SI joint before. And usually only women know about the pubic symphysis. Seemingly, that's just an observation. So the pubic symphysis is going to be anterior. So that is where our two innominate bones are going to connect anteriorly. So right where our two pubic bones will connect, we have this piece of kind of fibrocartilage, and that is our pubic symphysis. So here you can see our two innominate bones, the pubis, and then we have this connector cartilage piece. So that is where it's connecting in the front. It's anterior. It is amphiarthrosis, meaning that it really doesn't have any movement there. It does have a little bit of movement, and this is why I said usually women know about it, because in pregnancy, the pubic symphysis oftentimes separates to create more space, obviously, for a baby to come out. So it's not supposed to move in a normal person, but it can move a little bit, or if you have an injury to your pubic symphysis, it can kind of move and come out of line. So then we have our sacroiliac joint, our SI joint, which I'm sure if anyone has had back problems, you've probably heard of your SI joint. So your SI joint is connecting sacrum to ilium, hence sacroiliac. So sacroiliac joint is right here. You can see where the sacrum sits on the ilium of the os coxae, or innominate bone. So right here we can see we have our SI joint. And basically, it's confusing. So a lot of things say it's diarthro-amphiarthrosis. So what that means is some people say that there is no movement at all at the SI joint, while other people say, yes, there is movement at the SI joint. So what I've noticed is, in some people, there isn't much movement at the SI joint. Their SI joint is stable. In other people, they have a lot of movement in their SI joint, hence why some people have such issues with their SI joints, or their leg length discrepancies, or people like with scoliosis. Their SI joints will rotate and kind of get out of place, and that's why they have to get adjusted. So I fall more along the line of the SI joint can move and does have movement, versus people who refuse to believe the SI joint has any movement. Okay, any questions on that? No. Okay. So our last joint is going to be the hip. It does have a fancy anatomical name, but it's usually not referred to by that, so we just call it the hip. So the hip is going to be the head of the femur to the acetabulum So we know head of the femur to the acetabulum will be that kind of true hip joint. It is a synovial joint, which means it had that synovial fluid in it. It had that joint capsule, so that makes it the synovial joint. It has that synovial fluid. It is a ball and socket joint. So the acetabulum is the socket, and the head of the femur is obviously the ball, hence it's ball-shaped. So when it connects into the acetabulum, it is a ball fitting in the socket, which gives it more movement than any other joint, because now it's able to move in all three planes of motion. So your hip is very strong and very stable. So if you have hip problems or hip stability problems, you typically will have injuries further down your leg as well, because you're not stable from your base, the core of it. It is very strong because you have a lot of ligaments in your hip, which you don't often hear about. You have a labrum in your hip, which is kind of like a suction cup holding that head of the femur into the acetabulum. And you have a ton of muscles surrounding the hip. So in order to hurt the joint, you need to kind of go through all of the rest of that. So with our movements, and again, you don't need to have the degrees memorized, you just need to know the movement. We're going to have hip flexion, so that will be bringing our knee up, having a bend at our hip. We will have hip extension, which is going to be bringing it back. Some people say that hip extension is only to parallel with the other leg, and then it becomes hyperextension. But we're just going to refer to that as hip extension, so bringing it back. We're going to have hip abduction, which we should already kind of know all of these, so I'm going to take a quick. So we know AB means bringing it away, so hip abduction will be bringing our leg out, moving it laterally. And hip adduction will be bringing it back in. So hip internal rotation. Sometimes hip internal rotation can be a little confusing because dependent on if your knee is bent or straight changes where your foot goes. So what you need to know is that it's the femur rotating medially. So it's coming in. So if I have my legs straight and I want to do hip internal rotation, I would be bringing my toe would be pointing in, because you can see my femur will rotate medially. If my knee is bent and I want to do hip internal rotation, my foot's going to go out, but my femur is still coming in internally medially. So sometimes you can get confused if a picture of hip internal rotation is this way, but then you transverse it to having a knee bent and it kind of goes the opposite. So you need to look at what the femur is doing, not so much what the foot is doing. So then external rotation will be the opposite. The femur is moving laterally. So if I have a straight knee, that will be coming toe out. Usually people have a lot more hip external rotation than internal rotation. And if my knee is bent, my foot will be coming in. Again, my femur is rotating laterally. Okay, so these movements aren't typically classified as major movements, but you have what are called pelvic rotations or tilts. So you have an anterior pelvic rotation or tilt, and this is where the iliac crest and your ASIS, which we know is the very tip anterior aspect of it, is going to tilt forward anteriorly. So basically, if you have your pelvis, so here is my ASIS, if I'm going to do anterior pelvic rotation, this is going to come forward. So I would be rotating forward, kind of sticking my butt out. I'd be getting lumbar extension, so rotating forward. So that will be anterior pelvic rotation. Versus posterior pelvic rotation is where the iliac crest and your ASIS will tilt backwards or posterior. So again, if I'm in neutral, and we know that this is anterior, if I was going to tuck, so like tucking my butt under, that would be a posterior pelvic tilt, moving backwards. Now, why I agree with the train of thought that your sacrum has movement is you could have, this is not normal and you would be technically injured, you could have one side of your pelvis do an anterior rotation while the other side of your pelvis decided to do a posterior rotation. So then your pelvis would be completely misaligned. So that's what I actually have. I have one side of my pelvis that does anterior rotation, while the other side of my pelvis is in posterior rotation. So mine are completely kind of at cockamamie and cooked out weird, so that I have a lot of problems in my pelvis, like pelvis pain. So that's why I think it can happen. Or if you've ever seen, you've probably gone to a chiropractor and they're like, oh, your legs are a different length. And then they adjust your hips and they're like, oh, they're magically fixed. It's because sometimes your pelvis might anterior rotate or posterior rotate, making your leg appear shorter or longer. Okay, so this is just a preview of the muscles we're going to be doing next time. That will be our next class on Monday, right? So we're going to have our anterior muscles that are going to be our hip flexors. Now, it looks like there's a ton of muscles we need to do, but in reality, we've already covered a bunch of them. So the ones that are in black, we've already talked about. We talked about with the knee. So we aren't going to have to relearn them for this time because you should already know them. So the only new hip flexors we're going to talk about are going to be what's called our iliopsoas, which is a combination, oh, I see a spelling error, of our iliacus and our psoas, there should be an S right there, psoas, major muscle that's combined. And we're going to learn our pectineus, but you should already know your rectus femoris and your sartorius. So then if we look at our posterior muscles, which are going to be hip extensors, we already know these three because they are our hamstrings. So we're just going to learn our gluteus maximus and our 6 deep external rotators. Laterally will be all new muscles. We haven't learned any of these, but all lateral muscles will be hip abductors. So our gluteus medius, our gluteus minimus, our external rotators, and our tensor fasciae lata. And medially, we have 3 new ones to learn. We've already learned our gracilis. So we'll have our hip adductors, adductor brevis, adductor longus, and adductor magnus. So those are the muscles we are going to cover next time. Next lecture is the last lecture before your test. So, well, that's the last material you'll need to know. So probably we will do hip part 2 on Monday, right? We still have class. I get lost with all these wellness days. Let me see. Okay. So we can do it. Do you guys want to keep it on 310? Because we'll do hip and pelvic girdle part 2 on Monday. And then we'll probably do exam 1 Jeopardy on Wednesday. Then you have no class on Monday, so I had it on Wednesday. So we can either do it on Friday or we can do it on Wednesday. What would you prefer?
Wednesday.
Wednesday? Okay, so we'll keep it on Wednesday, 3:10. And we'll probably do an online activity Friday. We won't meet on 3-5. So then you're sort of get it like a 3-day weekend. Okay, there we go. You are good to go.